Anti-arrhythmic drugs. As far as pharmacology is concerned, they're high yield. Let's break them down. First, we have class 1, class 2, 3, and 4. Class 1 are the sodium channel blockers. It's very important to memorize the drug itself as well as the adverse effect. Class 2 is specifically beta blockers. You have non-selective and selective. We will talk about some of the key beta blockers that are used specifically for rate control. Class 3 are the potassium channel blockers. The holy grail of antiarrhythmics sits in this class. And class 4 are the calcium channel blockers. Let's talk about class 1 first. The sodium channel blockers they're broken down into 3 categories, class 1A, B, and C. The reason why they did that is because these 3 classes of drugs have different effects on the heart depending on the state of the person. If the person is exercising, they're working out, they increase their heart activity, these different drugs will have different effect on the heart. That concept is called use dependent. So in understanding use dependent, you need to say which one of these drugs are more potent when the person is exercising or when they elevate their heart rate. Class 1C is the most potent use-dependent drug. So if you memorize the drugs in this class and the clinical veneer tells you that this person is undergoing exercise or something and this drug has more of an effect, then you need to know they're talking specifically about class 1C. So use-dependent works in such a way that when the drug binds to the different cardiomyocytes, doing exercise, there's not enough time for the drug to remove its attachment to allow the heart to relax and go through its cycle. But just understand that 1A, 1B, and 1C, 1C is most use dependent. Class 1A, these 3 drugs, prokinamide, quinidine, and disopyramide. We say 1A is also one of the class of drugs that may cause prolongation of the QT interval, which increases the chance of torsades de pointes. Prokinamide is one of the drugs of class 1A. Its side effects is drug-induced lupus. Quinidine is another one that's very frequently tested. Its side effect is synchronism. Synchronism is when the person has GI complaints as well as myocardial toxicity. Then you have disopyramide, which is also part of this class, and its effect is prolongation of the QT interval. Now, all 3 of them may cause that, but disopyramide is the culprit most of the time. Class 1B, there are a variety of drugs here that have multiple effects in different pathology. Lidocaine, for example, we know is a local anesthetic, so it can be used for CNS depression, but it can also be used as a class 1B antiarrhythmics. Phenytoin, we know it can be used for a whole lot of other things, and it has a whole lot of other side effects. The ones that are important to remember here are hirsutism and gingival hyperplasia. Mexiletine is a drug that most frequently will cause GI complaints. Then you have tokinine, which is also part of this class. Class 1C, you deals with propafenone as well as fluconide. Then we move on to class 2. Class 2 are beta blockers. Also know that beta blockers are part of the class 2 drugs, and they also have antiarrhythmics property. Beta blockers here, you have specific and non-specific. In the specific form of beta blockers that are usually given, metoprolol, esmolol, and propranolol are the ones that are frequently given. Note that especially you want to give metoprolol in individuals who you see may have an elevated HDL. These drugs are very important, and if you want to consider the class of beta blockers drugs that causes or increases the person's survival rate, then you want to consider these ones: metoprolol, carvedilol, and bisoprolol. Then we move on. We said the non-specific beta blockers are the bisoprolol and timolol. Now, I use bisoprolol here as one of the drugs or the beta blockers that prolong the survival rate, but it's non-specific. But we have metoprolol, we have esmolol, and propranolol, which are the important ones that are very specific. As we move on to class 3 antiarrhythmics, we say these are the potassium channel blockers. Potassium channel blockers, we have 2 main categories here. We have amiodarone, which is a holy grail when it comes to antiarrhythmics, and then we have others like sotalol and defitelide. Amiodarone is the one that will be frequently tested. Why? Because it has a laundry list of adverse effects. One of the key areas where you have to consider checking when you're giving a person amiodarone is the lung. So you do pulmonary function tests. It causes pulmonary fibrosis. It also causes liver pathology as well, so you want to do liver function tests, and you can do thyroid function tests. Amiodarone, in terms of the thyroid, can cause hypo and hyperthyroidism, so you want to watch out for that. It can also affect the skin, causing the skin to have more grayish coloration to it. Then you have sotalol and defitelide, which especially can affect the potassium by leading to hyperkalemia. Again, remember these are potassium channel blockers, so they may increase the number of potassium in the serum. Then we have the calcium channel blockers, which we say are also used for rate control, but they're also antiarrhythmics. These calcium channel blockers may have complications such as edema, peripheral edema. This is the case where you may treat the person with giving them ACE inhibitor to treat the calcium channel blockers peripheral edema. This is a high-yield concept to remember. You should give this a star. Calcium channel blockers such as diltiazem and verapamil may precipitate peripheral edema. ACE inhibitor is the drug of choice to treat that. Again, seems to be a lot of drugs here, but if you take your time and just break them down into their various categories, you'll be able to memorize these drugs. For pharmacology, there's not a lot of extra logic here. Most of them are just memorization and also trying to find their adverse effect as well as their mechanism of action. Ladies and gentlemen, this is arrhythmia.